aided by the promise of free post-it notes, toffees and USB sticks. We do have the first one, that is Gillian Smith from NHS Lanarkshire, if Gillian is still in the room.
No? Okay. We promised to send it to her.
Does somebody want to take it on Gillian's behalf? Yeah. Do you want to pop it in?
We have to clap for somebody.
It's a £10 Amazon voucher. Easy now. And the second completed form is, I believe this is a bit of a standing joke among some people, is Jill Ellis.
Well done, Jill.
There you go.
So we're going to roll the prize over to next year.
It's quite a good one because Jill was actually late, so I don't know if she managed to get it. So I do have one remaining £10 voucher. Does anyone have a nearly completed form? The first one with a nearly completed form who gets themselves to the front to pick it up can have it.
No, I think we'll roll it over.
We'll roll over. Right. I'll hand you out to Mike.
Okay, thank you. Just really last few words. I mean, I think I'm going to say again that we need to work, and any pressure or feedback you can give to your boards or your organisation, that actually having a refreshed medical devices policy is something that Scotland needs. Sarah and the team at Scottish Government are willing, however they need to persuade those above them that this is something that's needed, because it's felt to be dangerous territory, because it actually feel it cuts across. But it ties into the stuff that Scott touched on, which is this about Scotland's economic future as well as Scotland's health future. I think there is no doubt that working with industry, working with academia is something that Scotland is good at. I'm pleased Ed Clifton's at the back. He's taken over some of the work with SHTG and the innovation portal that we run within NSS, working with Scott. And again, we need to hear what the issues are, but we also need to make it easy for industry to work with Scotland. It frustrates me to bits when I hear about great ideas and then I discover that the platform institution that organisations in Scotland are working with are UCL in London, they are the hospitals in Birmingham. We need to make Scotland easy to work with, and the discussion we had about clinical engineering is highlighting that we can do things in Scotland and we do need to work together. There's no question, and the discussion has rightly picked up, we need to improve reporting, and that needs to be, we have a confidence that when a report comes in we will be using that information for improvement. We will not be using it for judgment. Yes, there has to be a fair element there. If somebody's done something wrong, we need to work with them to understand why. But usually it's the system that's actually created the problem, so we need to find a way of improving the system. And to that end, when a report comes in, I think it came over in several of the presentations, we need to tell you, the reporter, what happened. What improvement actually came as a result of it, not just in your own patch but across the system. And I think that's a challenge I'm going to put on Innes and Irick in terms of the communication, not just about improving reporting, but I think we can improve it on the back of coming out. And I think the group that Peter presented, really where we start to bring Scotland together, to actually look at what's happening on safety alerts and how did they happen. But at the end of the day, it's about us. I hope that you all take something away from today. You think about, what am I currently doing that I could do better, I could be doing differently. And can I just say a huge thank you on your behalf to our speakers. And dare I say, an even bigger thank you to Chris and his team and to the conference staff here at the Jubilee for giving us an excellent. It is our intention to run an event next year. Yes. To make it. Who pays for it, seriously? No, seriously. I mean, to make it really meaningful, so that you want to take a day out of busy diaries, make sure that you correspond with us. Let us know what it is of interest. We will be in dialogue with you. We won't just tell you what the conference is about. We want to make it right. And hopefully the back-to-back of the work on decon and the work on medical devices is something. I'll also put a plug in for the other big HFS conference where we look at facilities, which is in November. And again, that's an opportunity for colleagues across the facilities in the States. And dare I say, I'm standing here as a doctor. We had an excellent presentation from the clinical advisor from MRHA. Please engage with your clinical staff back at base. We need them. They're the device end users, and they're more than welcome at these events as well. So thank you very much for staying. Thank you, and safe home. To make sure that it's easy to actually report, and much as Innes and the team in IRIC will do this from the centre out, it is actually something we require all boards and all organisations to make it easy to report, so it doesn't feel like I'll just put that off to tomorrow and tomorrow and tomorrow. It's to make it easy, and that there is actually some support to the staff that do make the initial report so that it can be followed up. And certainly we would be very keen to hear about things in IRIC. I think a couple of the talks also made reference to the reports that go down through Yellow Card to MRHA, and actually making sure that we get timeously those which happened in Scotland, and I know we've been working very hard to achieve that.
Just speaking to them last week about that and going through the systems with it. I think the gentleman over there was wanting to was a question.
I was going to ask, we were talking about increasing reporting, but earlier you had mentioned that in Northern Ireland they were reporting 3 times the number that we were. Have we learned why that is?
No, we haven't, and we're comparing apples and pears to some extent, so we have to be cautious about the numbers, but I think there's a lot to be learned from that. You can't just say, well, they're not quite the same, therefore there's no relationship. I think there is a relationship. I think Northern Ireland doing something, they're getting it better. They are smaller than us. If they're 1/3 their size, then I think you scale down to some extent, scale down the issues and the problems and the barriers and whatever. I think they have a closer knit community. They all know each other just that little bit better. So you do get issues with scale. I think, and when you imagine once you get into the scale of England, their problems are even more challenging to overcome when it comes to tackling under-reporting. But I think we can learn a lot from what our friends in Northern Ireland are achieving, and we will try to understand that.
Felicity, you wanted to come in? I'll come back.
In addition to what Innes and Mike were saying, in practical terms, we go into a campaign. We have printed a number of leaflets or little posters, and we will ask your help to put it in your strategic area, i.e. the toilets. To remind people that I think it exists and the procedure of reporting. The second one is we have been asking for a user group if they can put a little function in there to say if it is about if the incident related to equipment and medical device, we will ask whether it will be reported to IRIC, and we work with the equipment coordinator to see where the number match.
Yeah.
We need to identify where the number was in the local reporting and the national reporting.
Peter.
I think also, and I will be correct if I'm wrong in this one, we're dipping our toes into the area of terminology and looking at consistency and how we record these types of incidents. A lot of boards and organisations are using different words to record medical devices, so having consistency in the terminology will help, and also ultimately looking at the process as well, longer term.
That's very true, and I was just speaking to MHRA last week about that, and Malcolm Phillips from Lothian mentioned that the shared services people for clinical engineering have also been looking at harmonising data fields, so I can sense that we're actually coming together at just the right time, and Paris Shah of MHRA has been working across Europe to harmonise, mainly working with the manufacturers, because the whole manufacturing side, I've got through vigilance have an obligation to report incidents. So we're talking about user reporting here. But if we're all using the same data fields in the same format, then you can you can see how it all comes together very nicely. So quite good timing and a lot of benefits. I think are going to be coming along soon.
So, do we have any last comments? Otherwise, I'm going to ask Chris. Felicity?
Okay, yeah. I'm a little bit concerned. In relation to, we heard today a lot about the medical device, right? Unfortunately, some call it from only you. that would impose a number of new additional requirements. I wonder how that's going to impact in terms of the financial cost to the NHS. Because if we impact in the industry, we will have to take up the bill at the end. And we want to know if there is some kind of financial assessment at the Europe level, if anyone knows how much increase of the medical device it will become in the future.
So I think the way I would respond to that, and I think it's actually one of the pleas that Sarah actually said at the beginning of her talk, which is that this is a whole system impact that you're touching on, Felicity. And yes, I mean, whilst MRHA are in fact leading it because they are the recognised authority, for this, we do need to give some thought to how we in Scotland, actually respond to it, because what we don't want is 14 different solutions, from 14 boards or 35 different solutions from local authorities. We need to find a way of doing this in Scotland. And it ties back to, I think, that request of having a clear statement of where are we going with medical devices in Scotland, and perhaps the driver will be that there's legislative change coming, and it's why we actually need to have an updated national policy. It doesn't answer your question specifically, but I think it's something we can pick up outside, and I'm sure Sarah will be working with us on that. I'm going to suggest that we were going to try and work to just the back of 3 o'clock as a finish. I've been here right through since yesterday and have thoroughly enjoyed and been challenged by many of the presentations. Thank you to our speakers who've come from far and wide, even if some have relocated to Scotland. Well done. Long may you stay. It's obviously a reality that diary pressures and travel arrangements mean that some people have to leave. The fact that we're all still in the room, late into a second day of a conference, is a congratulations, so a gold star for all of you. Chris, from a sponsor's visit perspective, have we got a prize?
We do have 3 prizes, you'll be ecstatic to know. However, we do only have 2 completed forms. So if anybody else have a fully completed exhibitor form that they wish to submit, because this is going to be a bit of a sham if not. So we do have 3, so we may kind of allow a bending of the rules. So I'm pleased tonight, obviously.
Opportunity to see the devices just in a short time if you want to pick that up. And almost just at that end point, which is that plea, which is that we have many people with brains out there who are desperate to help the NHS, actually out with the health and care community, the engineers, but often they don't know what it is we need help with, and actually admitting that instead of doing the workarounds that we're all very good at and which we've really done because of austerity, is actually let's find a way of declaring what the issues are, and we can actually share it both with our academic and industry partners, and hopefully through today you've heard both from industry themselves, from Scott representing the Scottish Life Science Association. We have mechanisms of speaking to them, so please use us as a conduit towards that. So we have a few minutes for questions. I've chosen not to bring the panel up onto there, but there are quite a number of our speakers still in the room, so if there are particular questions, I'm sure we can direct the question to them. Anybody got any issues or a comment that you want to make, if not a question?
I've got a question for
Please.
Scott, if I may. The Department of Health, in conjunction with 3 universities, developed technologies for detection of prion proteins. One of the problems we had was that the universities who developed the products struggled to get them to market because of lack of funds. Is that the sort of area that your organisation can help with in the future?
Yeah, totally. So a lot of our members are university spin-outs, or they'll in-license technology from the universities, and then you can go out and get funding. And the funding that's needed, not the academic grant funding that's, even if you get £1 million, it's kind of at the top end, whereas for something like that...
company was a Scottish company, so it might be, we can have a...
Yeah.
Before we go.
Yeah, always happy, because there's always to us, everything there's opportunities and solutions.
Because I think one of the problems is that there's research goes ahead, and often the outcome of that research, they go into expert panel, for example, the guidance to our governments. But then you want to update your guidance that's been used by the NHS, but then they're in the product to enable them to improve. And I guess that's where the forums you work in, when we get the seed funding to help. It's just about, as we've been talking, it's that continual improvement. And sometimes what might seem a lot of money to a small company is chicken feed for the big companies who see startups come and go all the time.
Yeah, or the venture capitalists who have, literally billions sitting doing nothing.
But I think there's also a partnership, between the NHS, because again, often those small developers have got an enthusiastic clinician and they're solving something for that clinician. Sometimes getting that tested to find out, actually, does the orthopaedic community across the UK want that? I think the other side, and I think we've got to be quite clear from a Scottish perspective, that actually getting into the Scottish market and showing that you're selling in Scotland is a huge selling point, both elsewhere in the UK and elsewhere. So in fact, invest in Scotland is a really strong selling point. No disrespect to South of the border, but we do need to work across the four nations, because we are one system, and the focus is about improving care. And I think hopefully we can continue to build on a partnership that's been going on. Any other comment or question from? Please.
There's been a lot of talk about under-reporting of incidents on equipment and stuff like that. I was just curious to know, is there any specific actions that IREC or anybody else is taking to improve that at the moment, and what we might do to help that?
Minister Scott.
Yeah, so that's a good question.
Do you want to answer that?
So, yeah, it's a good question. I mean, we've known for a long time that there's indications of underreporting, not just at our level, at local level as well. So everybody's affected by this. It does nobody any good where we have, I think, what Donald Rumsfeld called known unknowns. So within the organisation, there's knowledge that an event has happened, but the people who can do something about it have no knowledge of that. So, and that's just as valid at local level as it is at our level. So we need to, first of all, go to the root of the problem. And there was a very good Canadian study done a few years ago which found barrier number one is to tackle recognition that an incident has occurred. And I think, we've talked about mesh, and I think that's a good example where people didn't recognise there had been an adverse incident, and they just dealt with it as clinical complications. Therefore, if you don't have that initial recognition, if you don't have the education in place to ensure incidents are recognised when they happen, they'll never get reported. So that's the first barrier to, I think somebody wants to pick me up on that point. Is it? Yeah, okay. So once we get the education right, once we ensure people recognise this has happened, then it's just about the motivation. I think the motivation is there. I think there's a very basic human motivation to ensure that harm is not repeated. Very often you see people on the TV news just being handed out £1 million and they say, well, I didn't do it for the money, to make sure the same thing doesn't happen to anybody else. And the cynical people say, come on, you did it for the money. But I don't believe that. I think money isn't going to do any harm. But I do believe people are absolutely genuine and they say, I don't want the same thing happening again. So it's down to us to have the systems in place to make sure that we can live up to that expectation.
So I would add to what Innes has said by a recognition that obviously just in the last few weeks Scotland has signed up to a new legal framework of duty of candour, and that will actually require all of us, from a clinical and an organisational perspective, to recognise that a harm or a near harm has occurred and be open with the end person that's happened. That actually is at one level legislation which seems like a big stick, but it is actually tied into a whole culture change, which is that the reporting is to be taken forward so we can investigate, learn and avoid it happening again. It's not to suddenly create lots of money for the lawyers in terms of doing ambulance chasing, but we're all going to have to work together.